this part 2 of the office techniques workshop. These are my disclosures. Dermatological practice is always associated with significant body of surgical procedures, and that's due to the increased demand on the aesthetic procedures and the increased risks of the skin cancers, and this have necessitated advanced dermatological surgical skills. Office techniques include many things like some of what you've seen earlier, including cryosurgery, electrosurgery, intradermal injections, biopsy, excisions, incisions, lasers, chemical peeling, dermabrasion, and scar revision. And for performing any procedure in an ethical and professional way, I have my own protocol for that, which is actually an 8-point checklist, starting with the indications, where I have to know exactly the diagnosis of the case that I'm going to deal with, and I have to span the body of the patient for any contraindications that might hinder the performance of this procedure. Then I have to set up my mind for a treatment plan, and then I go for the patient's awareness part and the consent. Then I go for pre-treatment and preparing the patient properly for the performance of the session. Then I go for the session performance itself, including all the parameters and everything. And then I go for the aftercare, which is crucial for every procedure, and documentation in the form of soft and hard copies of the patient data, in addition to photography for sure. So I'm going to talk today about two things, just the electrosurgery and the intralesional injections. And for the electrosurgery, we know that these are a group of techniques by using high frequency alternating current in order to achieve tissue ablation. The importance or the advantages of the electrosurgery include that it is an expensive procedure used for destruction of many parts of the tissue, including tumors with AZ hemostasis. In the older days, there was the electrocautery, which utilizes the heat generated in the electric wire due to resistance to the passage of electricity. Then this caused the destruction of the tissue, but this usually ended in scarring of the skin. But with the development of technology, we got the high frequency current treatments, where the high frequency current goes into the skin molecules, causing electrovalency changes in rapid agitation with friction and heat formation within the tissue itself. And this has been used for many purposes. As we see in the image, this is the bipolar coagulation, and this one is the electrofulguration, where the tip of the device does not touch the skin and covers superficial lesion of larger diameter, and then the electrodesiccation, which touches the skin. The electrocoagulation goes with this tip, which is like a metallic ball, causing coagulation of blood vessels, which are not deep in the skin, and then the electrocutting or section as the one used in surgeries. This is the shape of the device that we use. Some of them has a ground plate, others do not, and there is variance among the power of electricity in each type. When we use the device, we have to adjust the power, the exposure time, and we have to use the proper size of the electrode and avoid lateral thermal spread, which will lead to tissue necrosis and scarring. We have to have a salinated soaked gauze in always to keep the electrode tip always clean during the procedure, and to also cleanse the debris from the skin surface. We have to avoid patients having pacemakers or defibrillators, because the electromagnetic energy generated from the device might interfere with that and cause serious problems up to death for the patients. This is our setting, this is our device, these are the different probes that we shall use. This is the forceps, this is the anesthetic, and the cover for the device itself. And these are the different shapes of the probes. We have this pointed one, we have this semi-blunt one, and we have the one for the electrocoagulation, we have the one for the electrolysis, and the one for the cutting, and this semicircular one for the cutting of pedunculated lesions as well. As we can see over here, we are going to perform coagulation for this molluscum contagiosum on the eyebrow of this kid, where we have injected intradermal anesthesia, and then we go for removing the lesion, as you've just seen with the side of the blade, and then we cauterize the base as well. And you see over here where I'm going with the electrolysis probe, which has to be an individual probe for each patient for sure. and I go and I penetrate the dermal junction, and then I press and generate the heat down there, and then I'm able to get the hair with my non-toothed forceps. Also, for the coagulation of the spider angiomas and the superficial varicosities, I go with the probe into the vessel itself, and then I create energy in order to be able to coagulate the blood and the blood vessel itself. And this, the use of dermoscopy before and after. You see those minute warts on the eyelid of a child, and then immediately after removal by dermoscopy. And now for the intralesional injections, which has a very important part of our practice. And by default, it's injecting a substance into the skin lesion in order to reduce the side effects of systemic therapy and to provide maximal effects at the desired site, with the advantages of having the drug exactly delivered where it's needed, with full control of the physician over the dosage, and saving the patient annoyance of making repeated applications of creams or ointments, which can be removed by normal daily activities. When we go for the injection techniques, we can go for an insulin syringe or for the dermojet, which is high pressure jet therapy. But remember that the needle shall be a lower lock or a fused on needle, as we see in the image, in order to resist the pressure that will be created with the skin, causing resistance for the injection itself with the syringe. For the precautions, we have to follow strict infection control measures for sure, and shall go for skin pinching, especially when we are using the dermojet over areas with loose supporting connective tissue. We see over here the different videos of injection. For the first image, we are using a fused on needle syringe, and we are going to inject pentavalent antimonials, pentostam, for this case of leishmaniasis patient. As you see over here, I go with the syringe 2 millimeters beyond the edge of the lesion, and I then aspirate in order to make sure that I'm not injecting in any blood vessel, and then I inject slowly. The general rule is stab quickly and inject slowly. I inject 0.1 cc from the medication at each point, and I create injection points 1 centimeter apart. Also, for the second patient, over there, similarly, we are doing that, but for a bigger lesion, and you can see with fast dubbing speed what we are doing for the patient over there, and each 1 centimeter spacing between each single injection point, and for each one, and I aspirate and I inject 0.1 cc of the drug. And then for the last video, you will see me using the dermojet for difficult to be injected sites by the insulin needle, like the nail matrix in this patient suffering from lichen planus of the nails. You see the tip of the device is perpendicular to the skin and is 1 centimeter away from the skin lesion. Intralesional therapy actually can use steroids, as you all know, and this is a very interesting paper that has published all the intralesional drug therapy in dermatology. It was published 4 years ago in the Indian Journal of Dermatology, Venereology, and Leprology, and there are the indications of the steroid. Definitely, we use higher concentration of steroid for thicker keloids, then the concentration decreases as we go for scars, then for autoimmune disorders, then for inflammatory disorders. Also, we can use the 5-FU in cases of psoriasis, in cases of keloids mixed with triamcinolone acetonide, in cases of warts, especially periangual and plantar ones, and in some cases of BCC and squamous cell carcinomas as well. Similarly, there is currently the trend and the era of the intralesional immunomodulator injections in order to stimulate immunity, non-specifically against other disorders like warts, for example, like the use of the MMR, the use of the BCG, the use of the PPD, which is the purified derivative of the tuberculin test, or the candida antigen itself, in different concentrations for sure, for maximally up to 6 sessions and reassessment for the patient. Also, there is a use of different types of interference for different types of skin cancers and proliferating disorders, which gives good results as well. also the use of bleomycin, which I find very beneficial in cases of resistant warts, and also the methotrexate, especially in cases of psoriasis. And by this, I end my presentation, and I hope you liked it and you enjoy the rest of the conference. And